Morning, everybody. It's a pleasure to get today up and going. I think that we're all looking forward to today. I think yesterday was sort of diagnostics, and today it ramps up into therapy. So it's going to be, I think, a really wonderful day. And I think we're starting it off in a wonderful way as well with the delivery of the Micheal Levy lecture. I don't have a formal introduction to Mike Levy because I don't think that he would have wanted it. Mike was a wonderful, warm, extremely humble individual. He was originally from Columbia, South Carolina, matriculated to the Mayo Clinic, where he trained with a former fellow of mine, Moritz Wiersma, and took to EUS when he was working at the Mayo Clinic. And he was a regular attendee of our EUS conference. Every year we had Mike Levy come, and he was so thoughtful and careful and so bright. He always had wisdom to share, was always a little bit reluctant to share it because he was sort of humble and so forth. But he was really a very, very special individual who we lost way too soon. So we've established the Mike Levy lecture in his honor, and it's a second great pleasure for me today to introduce Girish Mishra. Girish is sort of one of my heroes because he came to MUSC as a fellow, worked hard, elected to do a year of EUS, but he did that as part of a 3-year program. So it wasn't like he had this devoted year of EUS. And then he's morphed that into just an amazing career, going to the University of Florida and then eventually going to Wake Forest. And he's risen now to be professor of medicine. He's chief of GI at Wake Forest. And I've just had the pleasure to sort of experience his career along with him. He's just an energetic, bright, warm, friendly, wonderful person to be around, and I think we could not have made a better choice than Girish Mishra to deliver this year's Mike Levy Memorial Lecture. So we've asked him to talk about a thoughtful roadmap to endohepatology, and so Girish, please come and take the podium and welcome, my friend. It's great to have you.
Good morning, everyone. Dr. Hawes, thank you so much. Want to also, with Dr. Vardar-Julu, Dr. Bang, the entire Orlando Digestive Health, thank you for asking me to deliver the Mike Levy Memorial Lecture. I am so honored and humbled. You know, Mike, Rob just mentioned some of the characteristics. Many in the audience had the privilege of knowing and working with Mike. But for those who didn't know him, just some characteristics I think that hopefully you'll remember. He was so innovative. He was ahead of his time. Deep thinker, humble, helpful, always collaborative. He was never caught up in fame. I mean, despite his numerous publications and accolades, he always sought the truth, and he's an amazing teacher and loyal mentor. Mike, my friend, you're still part of this amazing EUS family and faculty. So when Shyam asked me to provide a roadmap of, endohepatology, I think anytime there's a roadmap and you want to look forward, you always have to look back and say, where have we been, before we can figure out where are we going. All of you have been comfortable with transregular portal biopsies, percutaneous, but that's not what I'm going to spend my time talking to you all today about. It's going to be about EUS-guided portal pressures, EUS-guided liver biopsies, not talk about TIPS or Berto, how about EUS-guided Variceal coiling, EUS-directed TIPS placement perhaps? So that is the roadmap that we're going to follow. This is not a totally new topic. This was first developed in 2012 with Dr. Chang and Sam Rosena. They really set the framework, and Jason provided some of the slides that I'm going to use today. They made doing liver cool again for endosonographers. Many aspects of this slide were touched yesterday by the different echoendoscopes, so I'm not going to cover all of endohepatology that's available, but really focus on a couple things. Portal pressures, intraportal systemic shunts, we'll briefly talk about that. Liver biopsy, Variceal banding and glue. So those are the 4 elements that we're going to talk about. So here are the objectives. We're going to briefly go over the physiology of portal hypertension, why EUS is ideal, how to perform EUS-guided PPG. You saw Shyam do this yesterday. We'll just go through some theory with that. How does it compare to the gold standard? Novel data on EUS portosystemic shunt interventions, and discuss how EUS liver biopsy compares to percutaneous and transjugular, and briefly how do you perform biopsies and which technique is best. And then we'll go over how does it compare to Variceal glue injection and coil insertion with endoscopic. So this concept is not new. This has been around for a while. Groups from roughly 18 years ago from Harvard and Johns Hopkins and UC Irvine, they developed this. And the initial data was more porcine and then later extrapolated to humans. Really, the efforts have gone away from the technical aspect to more clinical applications. And our own Dr. Eunjin Shin was part of the group with Sam Gade, who's in private practice here in Orlando, Biscaglia and Sergey Kansavoy, where almost well over a decade ago, in 2008, they showed the first sort of porcine models of how you can actually access the portal vein in pig models. Fast forward to 2016, and the group at UC Irvine really took this to the next level and did portal pressure sort of insertions of the needle and the transducer. So this is Dr. Ken Chang and Jason Samersena and their group that really brought it from porcine or pig animal model to humans. Now, we talk about transjugular biopsies versus our own EUS-guided, and on the left there, you see what sort of traditional with transjugular approach. That's really when you do the wedge pressure, and that's what we're measuring. So we're not getting a true portal pressure measurement. When Shyam was showing the liver biopsy and the PPG measurements, he accessed the portal vein and the hepatic vein, and the pressure in the portal is slightly higher than the hepatic vein. However, this difference should be no more than 5 millimeters. When it's greater than that, then that's when portal pressure hypertension is seen. This is the device. You can see the schematic of accessing the hepatic vein and the portal vein, and then the transducer manometer, and you saw how Dr. Vardarjulu was doing this with the text where you did measurements. You get an average of 3, and that's how this is performed. This slide, I just want you to focus on a couple things because I've sped it up in the interest of time. Look when we measure the hepatic portal pressure, the Doppler. I think when you're first starting, it's really important to know where you're at. So Doppler's signal that is different for the hepatic vein versus the portal vein. And this slide was lent to me by Dr. Shami. This is a wonderful review if you're doing anything with endohepatology that was published, and I urge all of you to read that. So this is really fast, but I want you to focus your attention when the needle is inserted into the middle hepatic vein. Look at that Doppler signal. It's an ASVD with the atrial systole contraction. So that's real important that you do Doppler, and that's why when I was on the panel, I asked Shyam, just so you all know what you should Doppler first before putting the needle in. And this approach, the needle went through the middle hepatic vein and coming back, and then you push the saline and clear it out. Next, as Dr. Fauze mentioned, the portal vein has a glycine capsule. That's what gives it that very bright hyperechoic rim, so that automatically kind of know what the portal vein is. And then the Doppler signal is much more monotonous here in the portal vein compared to the hepatic vein. So that's how you know the difference between the two vessels. And when you're first starting doing this, you please should do this approach before inserting the needle into the vessels. A wonderful review that you all should review. So how does this correlate to liver histology, right? Yes, you can measure it, but what is the clinical sort of correlation? Numerous studies. We're part of a large multi-center study with Dr. Harshit Kaur at Geisinger. This, however, is just published with Jason Sammarsenna as the lead author, multiple investigators. And in this study, the key points with 373 patients, there was a very high technical success. The higher the median PPGs, the greater sort of clinical end-stage liver disease, such as variceal bleeding and also portal hypertensive gastropathy. So EUS PPG was the best overall predictor of biopsy-proven cirrhosis. So not only can we perform PPGs, but clinically it correlates. Now, yesterday in the history of EUS, Dr. Hawes showed the sort of advances in EUS. And one of the big things that, I mean, Shyam and Rob and the whole group, they've brought so much to EUS. But I think the biggest thing is the scientific rigor. We never had prospective studies. So yes, you can make comments on retrospective studies or meta-analyses, but you really need prospective studies. Now, we don't have prospective randomized studies, but just this year, there's 2 studies that I just want to highlight. Don't get caught in the weeds, but the first study, it was out of Belgium, as well as 2 centers in Spain, and they did concurrent transjugular pressure measurements followed by EUS, and then in a subset of 15 patients with TIPS placement. And the Pearson correlation coefficient between the 2 was really, really high, well over 0.8 to 0.9, so great correlation. There was, however, a caveat that with the EUS-guided approach, the pressures first with propofol were higher. So that's why right now most of these measurements are done with general anesthesia. Somebody from the audience asked, why is that? It probably has to do with something with the preload with anesthesia, but I don't have answers. So that's one study on the left. The other, 30 patients with chronic portal hypertension and the different measurements. Again, a very high ICC of over 0.8. Excellent correlation between EUS and transjugular approach. So finally, we have prospective studies that show that our approach with EUS is good at correlative. So how do we put all this together, transjugular versus EUS-guided? Transjugular is validated, however, it's indirect. There is radiation contrast exposure. You really get pre-sinusoidal and post-sinusoidal measurements. You don't get sinusoidal or true sinusoidal pressure with transjugular approach. With the EUS-guided, you get direct measurements of both the portal and the hepatic vein. Validation studies, as I've shown you, are ongoing. There's no radiation and contrast exposure, and there's true sinusoidal measurements. So what are the effects of GA on pressure measurements? Those are the questions that we're going to have to answer and further validate. Really exciting kind of, that's the beauty of EUS, is we're just pushing the next frontier. This next, more of an observational, very small study out of Chandigarh, India, Dr. Sahaj Rathi and colleagues from PGI did this. And now Dr. Rathi is at VCU, MCV in Richmond, Virginia, so he and I have had lots of personal correspondence to sort of use his videos and show his study. And what he did is in a subset of patients that had hepatic encephalopathy because of shunt occlusion, he went in and coiled the shunt directly from a transgastric approach and was very successful in 7 patients. So perhaps this could be an alternative to Berto that we're using. He's also shown this approach with EUS-guided bubble contrast study for diagnosing hepatopulmonary syndrome and also for assessment of Budd-Chiari. So there's expanding roles for EUS in sort of chronic liver disease and complications of liver disease. Now, this is an early study, and Excuse me. So what he does is with the EUS linear echoscope going right into the splenorenal shunt, you want to get the linear scope away from the portal vein because you don't want to inject the glue or the coils to where you can get systemic movement. And then the other key is you want to go where there's a bend so the glue and the coil is going to remain at that bend and not go distal. And here's the case study of a 74-year-old patient with NASH cirrhosis, overt encephalopathy. You can see the large shunt that's developed there and by CT in the video right there. So then this patient came down and on the Doppler study, the flow was 20 centimeters per second. I've sped up the video in the interest of time. He injects a coil and looks at the Doppler, and the flow has now decreased to 10 centimeters per second. The patient went home, was doing well, but then came back because of recurrent hepatic encephalopathy. So he takes the patient back and inserts a different coil, and you can see the coil had remained in there. The other point of this video is that there's no distal migration of that coil and stent elsewhere in that shunt system, and that's what he's showing right there. So very sort of novel approach to transgastric shunt placement, and you can see the CT scan and the imaging large shunt, and you can see the coils, and that shunt is entirely obliterated. This is the 7 patients. 2 patients required reintervention, and the time that he does this, it's anywhere from about 15 minutes to 30 minutes, so not very long. Can we take this to the next level and do TIPS placement, right? So that's sort of the next frontier. These, again, it seems like Unjin and their team with Jonathan Biscaglia and Sergei Kantsavoy, they were always, have always been thought leaders. And in 10 pigs, what you can see here is that the stent is between the portal vein and the hepatic vein, and successfully place these different types of stents. More recently, out of South Korea, there's a stent in the portal vein, and at necropsy, the stent was in situ. So we're not quite there because there's no human studies with EUS-guided TIPS or stent placement, but you never know. I mean, just look at where interventional EUS has come over the years. We're going to shift gears with the EUS-guided liver biopsy, and I think this is something that is easy to do, but it can't be cavalier. One should not be cavalier in performing this. So why perform a EUS-guided liver biopsy when we already have a percutaneous and other approach? How successful is it? What's the quality of the biopsy? What's the optimal technique? And how does it compare with percutaneous? And what should the performance target be? So these are some of the reasons why I would want to do EUS-guided biopsy. There's no challenges with body habitus, less painful. You can Doppler the images for blood flow, and you can get the left and the right lobes of the liver. With the transjugular approach, there's a 2.5% complication rate, potential hematoma, carotid puncture, and IVC ruptures have been reported. The schematic of this slide was lent to me by Dr. Harshit Kara. This is Dr. Shivangi Katari, who's in the audience, her brother at Geisinger. She's at the panel, sorry. And you can see how you access the different lobes. Very easy to access. One of the things that on the panel we discussed during the spleen biopsy case yesterday, it's not hard to do. But in patients with chronic liver disease, you could have hepatomegaly and splenomegaly. It is really important that you prove to yourself where the spleen is and where the liver is, because the echo texture can often look very similar. And because there have been cases where folks have unintentionally, yesterday we did an intentional splenic biopsy, but unintentionally biopsied with a 19-gauge needle the spleen, and the patients have bled to death. So be really careful as you're starting this out. The other thing that's important is you want to get at least 2 centimeters and over 11 portal triads by the AASLD criteria. I won't go through the merits of the different needles. You can see all the needles that are available to perform this. One of the largest prospective studies done, again, by Geisinger and Dr. David Deal and Harshit Kaur and others, and you can see that Shyam and Ramesh from our groups here were involved, and over 110 patients. You can get excellent quality, the length over almost 4 centimeters with the number of portal triads that you need. This is just a very short video that shows the liver biopsy technique. You want to measure the depth. You want a Doppler to make sure there's no vasculature, and the way this is being done, these are actuations. So it's one biopsy, and there's going to be 3 actuations. And after the 3rd actuation, I think when you're first starting out, it's important to put the Doppler on, because if you see a lot of blood, that suggests that you could have had a post-biopsy bleed. And there's techniques that are out there that show how you can mitigate that. And on the cup, we made a big deal yesterday about what is a true specimen. This is a true specimen right there where it's clear versus clot over there. So this is kind of very nice approach here. So the next couple of studies look at the different techniques. 19 gauge, this was a large multi-center study with 1 pass, 1 actuation with the wet suction technique. In this study, there were 36 patients that had abdominal pain, which is a fair number. The next several slides look at comparing EUS versus percutaneous approach in the interest of time. Here's the take-home summary. Percutaneous biopsy, you get a longer sample with more triads versus EUS biopsy. EUS biopsy and transjugular are about equal. Efficacy similar, great yield. However, there can be some bleeding, as noted in the liver capsule here, so be careful and take your time and do this thoughtfully. Shyam's always told us you got to do prospective randomized studies. There's 2, one on the yield and the other in technique. Dr. Neil Sharma, who's on the panel here, did the technique prospective randomized study. In terms of the yield, published. The take-home summary is that the yield with EUS-guided versus percutaneous is similar, slightly less triads or length with the EUS versus the liver biopsy, but clinical sort of efficacy is identical. With Neil's study, it's called the block study. It just got published. 6 centers, 153 patients. The histologic outcomes were superior in the wet suction technique versus the slow pull. Greater number of portal triads, and the histologic diagnosis was higher with the wet suction versus the slow pull, and the length and the adverse events did not matter. So to try to put all this together, the technique matters. I didn't show you the core, straight versus core, but core needles, 19 gauge, wet suction, heparinized is the way to go, and we can do this safely. Finally, just a little couple points about the quality indicators. Yes, you can do this liver biopsy, but how good are you? So there's finally data that we put together in a large, very well-known investigators. This quality indicators comes out every 10 years. It was just published in GIE. Related to all aspects of interventional and diagnostic EUS. I'll just focus your attention on liver biopsying and sampling and portal pressures. And the take home is that if you're going to do EUS-guided liver biopsy, you should achieve success at least 85% of the time. In terms of complication, the bleeding rate should be less than 5%. Finally, the last 3 slides with EUS-guided gastric variceal therapy. This is very exciting. How is it performed? How efficacious and safe is this? How does it compare to endoscopic variceal therapy? And you can see this is a Nestor coil, the different areas of varices that form. And just a couple words about coil embolization and glue. The coils actually serve as a scaffold for glue to reduce the risk of glue embolization systemically. Coils are made of soft platinum and the different size coils with the different size needles. The other approach that's kind of exciting is instead of glue, this was from Marvin Yu, and you can see he's using Surgifoam and cutting this and making a slurry. So this is available in your ORs. You take your Surgifoam, you mix a slurry, and this can be used in lieu of glue and works very nicely. This last two slides, here's a video from Dr. Binmoller. Large gastric varix, IgV1. He's measuring the size of this varix. It's pretty large. It's about well over 4 centimeters here. And then he places a glue with a 19-gauge needle. It's a 2-centimeter glue, and this was done in 152 patients, 5% that were actively hemorrhaging, 69% with recent bleeding, and then 26% with primary prophylaxis. Once the EUS confirmed the obliteration, the post-treatment bleeding was only 3% on follow-up. So quite successful. There was a residual 3-centimeter varix, so he goes back and repunctures and places a smaller coil with a small amount of cyanoacrylate glue. And you'll see in a couple seconds here, that the endoscopic appearance was remarkably better, and there's duration. This is the initial post-injection treatment with the glue and the coil, and in 3 months you can see right here the varix is completely gone, and this is durable there's no residual varix on EUS, and this is 9 months therapy. So this is the last slide. This is a prospective study with a multi-center study, 2 centers in India, AIG, and PGI in Chandigarh, with 2 centers in Italy. And Dr. Laktakia, who is here with us and probably doing some cases. And you can see the images, but I just want to show that in 276 patients with gastric varices that were randomized to EUS-guided approach versus endoscopic. With the EUS approach, the rebleeding was very low. The obliteration was very high when you compare that to the endoscopic approach. So in conclusion, EUS-guided PPG measurements are reproducible and correlate with gold standard. EUS-guided interventions for spontaneous shunts may become an option. It's early. We're not quite there yet for EUS-guided TIPS placement. EUS-guided liver biopsy is feasible. 19-gauge core wet suction is the best. EUS-guided Variceal placement is feasible and more effective than endoscopic approaches. So finally, just want you all to remember Mike Levy as a very fun-loving guy. He loved the company of others. He never complained. He never said no to sharing and helping. He's deeply loyal to his Southern roots, as Rob had mentioned. He loved his Southern traditions and his USC Gamecocks. In this picture with Mike, more in the casual sense, Andy Storm, who's at Mayo and will be joining our group at Wake Forest. So with that, I thank you for your attention. I'm deeply humbled and honored that you all asked me to do this, and I hope I didn't disappoint you, Rob.
Fantastic. Thank you so much, Girish. Awesome. So Vivek Kumbhari is going to present Girish with the plaque for the 2025 Mike Levy lecture.